So you can start presenting so that I can share more.
Okay.
Just press the Chrome on the taskbar.
Yes, Chrome is there.
Yeah, just press that, and now press the other screen and stop presenting.
I am already presenting.
Yeah. So, just stop presenting so that I can share the flyer and we can start. So just press the Chrome thing, go to the next screen. Yeah, press that screen. Yeah, and now and then you stop presenting from there. Press stop presenting.
Stop presenting. Yes.
Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 12F, and which is respiratory pathology, and we are streaming live from Kolkata. We have a very interesting topic, which is alveolar filling lesions of the lung. And to speak on that, we have Dr. Sukanta Chakraborty, who is an MBBS from Kolkata, an MD from the famous BJ Medical College, Ahmedabad. He is a histo-cytopathologist with invasive diagnostic procedure. He is an expert in that. He is also the lead assessor in NABL and the lab director of Theism's diagnostics and consultant at Kothari Medical Center. He's got various international and national publications and also a co-author in the Springer book. Before I ask Dr. Chakraborty to take over, let me request you to keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Chakraborty, sir, please share your screen and let us start. We are live on YouTube.
Yes. Yes, is it visible now?
Yeah, just make it full screen, please.
Yes.
Yeah, fine, please start.
Yes. Thank you all who are in this talk of alveolar filling lesions of lung, and thank you, Dr. Nadim sir, for giving me this opportunity. So we'll continue with the same line of day before yesterday. We discussed interstitial lung disease, and in the same spectrum, bit different topic today is alveolar filling lesions of lung. So let us start a brief discussion on alveolar filling lesions. Now, what is this? Alveolar lung diseases are a group of disorders characterized by pathological insult involving mainly the alveoli. Obviously, the alveoli can be imagined as an empty cup, and alveolar diseases are classified according to the content of this cup. So, they are characterized by filling of the alveoli with materials that impede its normal physiological function, which is ventilation. Of course, the normal physiological function of alveoli is ventilation. So, alveolar diseases can be localized or focal or diffuse. Names of the conditions depend upon the content of the material filling the alveoli, the cup. So, before we discuss the different types of alveolar filling lesions, some authors described pulmonary pathology in 6 basic patterns. Pattern 1 is lung injury, acute lung injury. Pattern 2 is fibrotic, and pattern 3 is cellular infiltrate. Pattern 4 is alveolar filling. Pattern 5 is nodules, and pattern 6 is minimal change. So, if we describe our pulmonary pathology in these 6 basic patterns, pattern 4 is our topic of discussion today, that is alveolar filling. So, patients with alveolar filling pattern biopsies typically present acutely or subacutely with cough and shortness of breath over months to years. The imaging studies show ground glass infiltrate. In this era of COVID, we are very familiar of this term GG, ground glass opacities or ground glass infiltrates, GGO, or areas of consolidation. This consolidation is the radiological correlate of alveolar filling. So, to classify a disease as alveolar filling lesions, air spaces should be filled from scanning magnification. The biopsy may be blue or pink depending upon the content of the alveoli. So, basically types of alveolar lung diseases are according to the content of the alveoli. Alveoli filled with serous fluid is edema or pulmonary edema that may be cardiogenic or non-cardiogenic. We'll discuss that. And alveoli filled with blood are actually pulmonary hemorrhage, commonly due to vasculitis, example chart straws or any other vasculitic lesions which affects the lung as a predominant organ. Now alveoli filled with pus is pneumonia, of course, and alveoli filled with proteins is alveolar proteinosis, and in case it is amyloid type of protein, it is amyloidosis. And alveoli filled with malignant cell is bronchoalveolar carcinoma, which is a older terminology, of course. Now it is classified into a kind of lipidic pattern of adenocarcinoma. Alveoli filled with calcium deposits is alveolar microlithiasis. So these are the broad categories of alveolar filling lesions according to the content. Now, first of all, pulmonary edema, alveoli filled with serous fluid. Now, pulmonary edema can be either due to cardiac disease, cardiogenic edema, or non-cardiogenic. Most cases of non-cardiogenic pulmonary edema are due to acute respiratory distress syndrome or ARDS. So, ARDS will be a significant part of our discussion of alveolar filling lesions. Now, cardiogenic pulmonary edema is commonly seen in heart failure. It starts as an interstitial edema before it turns into alveolar edema because the pulmonary veins lie in the interstitium. As the hydrostatic pressure within the vein rises, they leak into the interstitium first and then progress to fill the alveoli. So, now non-cardiogenic pulmonary edema are, as I said, ARDS, chemical pneumonitis, drug-induced pulmonary edema, and transfusion reaction are the most common causes. So, they result from direct increase in capillary permeability as a result of microvascular injury. So, pulmonary edema, there is centrally located bilateral symmetrical diffuse alveolar opacities emitting from the hilum and spares the periphery. So, butterfly or bat wing sign. Usually pulmonary edema causes homogeneous opacities, but sometimes they can cause nodular or blotchy opacities. So, to continue with radiology, airborne bronchogram sign is there. This is a sign seen when the alveoli are filled with fluid and the terminal bronchioles and bronchi are devoid of fluid. So, they are filled with air. So, there will be an alternate black and white area which is called air bronchogram and which suggests consolidation. The bronchioles appears as radiolucent and white is radiopaque opacities. This sign is specific for alveolar disease but non-specific for the cause. So, any kind of alveolar filling lesion will give a radiological sign of air bronchogram. So, pulmonary edema, pulmonary hemorrhage, pneumonia, alveolar carcinoma all looks the same. So, this is a histological picture of pulmonary edema. We can easily see the entire alveolar spaces are filled with proteinaceous material or fluidish material. Next comes pneumonia. Now, pneumonia will be discussed in details by another speaker as infectious diseases of the lung. So, I will just quickly flip through, pneumonia is a condition characterized by an infectious inflammation of the lung parenchyma and deposition of pus within the alveoli. So pneumonia can be caused by bacteria or fungi or viruses like cytomegalovirus. Among the fungi, most common is Pneumocystis carini, and patients with pneumonia presents with dyspnea, purulent sputum, fever, tachycardia, and maybe hemoptysis like in cases of tuberculosis commonly. So complications of pneumonia include lung abscess, septicemia, empyema. Rarely arthritis and neurological symptoms in atypical pneumonias like mycoplasma. So pneumonias are termed typical or atypical by typical pneumonias are pneumonias caused by Streptococcus pneumonia, pneumococcus, and all other pathogens are atypical pneumonia. The typical pneumonia is clinically dominated by respiratory symptoms, and atypical pneumonia is clinically dominated by symptoms of fever and malaise more than the respiratory symptoms. So another classification of pneumonias can be airspace pneumonia or lobar pneumonia. In this type, the infection is confined to a single lobe, and there is usually one patch filling the whole affected lobe. This type is seen in pneumococcus, legionella, pseudomonas, and primary tuberculosis infection. And lobar pneumonia is characterized by an air bronchogram sign. And next is bronchopneumonia. Bronchopneumonia is characterized by an infection that starts in the bronchioles and small bronchi walls and then spread to the alveolus. This is seen again in Staphylococcus, in Haemophilus influenzae, and mycoplasma. And third is interstitial pneumonia. This type is characterized by an infection that involves the interstitial septa and giving reticular interstitial pattern on chest radiograph. This type can be seen in viral infections like influenza, varicella, and mycoplasma infections. So these are lower and higher power view of pneumonias. The alveolar spaces are filled with neutrophils and necrotic pus-like debris. Next comes ARDS, or acute respiratory distress syndrome. As I said, as we have discussed interstitial lung disease, keeping in mind the IPF-UIP pattern as a prototype, in alveolar filling lesions, ARDS will be our most important prototypical category. So ARDS is defined by an abrupt onset of significant hypoxemia and bilateral pulmonary infiltrates in absence of cardiac failure. So non-cardiogenic cause is necessary to term it as ARDS. And damage to endothelial and alveolar epithelial cell both is characteristic of ARDS, and it is histologically characterized by the formation of hyaline membrane. So this hyaline membrane is a key histological feature of ARDS. Now, what is the pathophysiology? This is a schematic diagram of a normal alveolus with alveolar air spaces, type 2 pneumocytes, alveolar macrophages, and there is an intact surfactant layer. Deep to that is interstitium, and deep to that is endothelial cell, endothelial basement membrane. This is the vessel, and fibroblasts are there in the interstitium. Now, when there is injured alveolus during the acute phase, there is protein-rich edema fluid in the middle. How it occurs? There is sloughing of bronchial epithelium, necrosis of apoptotic type 2 cells, where type 1 cell, necrotic or apoptotic type 1 cell, whereas type 2 cells are still intact, and there is a RBC extravasation within the alveolar spaces. The neutrophils are activated, releasing various cytotoxic chemicals like leukotrienes, oxidants, proteases, TNF-alpha, interleukin-1. All these are again secreted by alveolar macrophages, and IL-8, IL-6, IL-10, these are now familiar terms to us, and this fibrin are also released, and basement membrane is denuded, and this kind of newly formed membrane is called hyaline membrane. And in the interstitium there is migrating neutrophil, proteases, and widened edematous space in the interstitium. And in the vessel there is platelet aggregation, neutrophil activation, swollen injured endothelial cells, releasing these interleukins. So this pathology starts from the vessels to the interstitium and to the ultimately filling the alveolar spaces and forming a hyaline membrane in the periphery of the alveoli. This is in short the etiopathogenesis of alveolar filling lesion in ARDS. So what are the causes of pulmonary and extrapulmonary origin? First of all, there is direct lung injury causes like infectious pneumonia and aspiration of gastric contents. This is a common cause of ARDS. Aspiration of gastric contents or aspiration pneumonitis. And less common causes are pulmonary contusion, fat emboli, near drowning episode, inhalation and injury like particles or gas, reperfusion pulmonary edema after lung transplantation or pulmonary embolectomy. And what are the indirect lung injury causes? Among them common are sepsis, severe trauma or burn, especially with shock and multiple transfusions. And among the lesser common causes, there is cardiopulmonary bypass, drug, acute pancreatitis, autoimmune diseases, and transfusion-related acute lung injury. So, these are the causes of ARDS. But now, what is the pathogenesis? As I explained in the diagram, just a quick recapitulation of the same thing. Endothelial activation may be secondary to pneumocytic injury, then adhesion and activation of neutrophils and release of inflammatory mediators, accumulation of intraalveolar fluid and formation of hyaline membranes due to leaky capillaries and surfactant abnormalities, and resolution of injury. But this resolution is usually impeded by epithelial necrosis and inflammatory damage. So what I said in the diagram, again a repetition of the pathogenesis. Now coming to the clinical features. The most important clinical feature of ARDS is acute and progressive respiratory failure. It usually starts 12 to 48 hours after the initial insult, and there is shortness of breath, dyspnea on exertion followed by dyspnea at rest. And there is hypoxia, and the PaO2 FiO2 ratio is less than 300. Ultimately, there is often sepsis and multi-organ dysfunction. So, respiratory dysfunction and physical disability may persist for months after the remission of the original ARDS with very gradual improvement. So, now coming to the radiology. Severe ARDS is demonstrating widespread ground glass appearing opacities, GGOs, in both the lungs. And in X-ray, there is exudative or acute phase for the initial 7 days, followed by the proliferative or intermediate phase where there is diffuse coarse reticular opacities in that second week, and fibrotic to late phase after 2 weeks, where it can be normal, it can be coarse reticular as per the resolution of the disease proper. So now coming to the CT features. In computed tomography, exudative phase shows patchy to diffuse ground glass opacity with or without interlobular septal thickening and dorsal consolidation due to infiltrate. In next proliferative or organizing phase, there is GGOs with bronchiectasis and bronchiolectasis, and there is volume reduction. And in fibrotic phase, there is septal thickening and reticular shadow within the ground glass opacities, and peripheral cystic and honeycomb-like lesions are there due to fibrosis. Now coming to laboratory features. In lab, ABG is the most important to evaluate and to follow up a patient of ARDS. There is hypoxemia, there is FiO2, the ratio of pulse oximetric oxygen saturation to FiO2 may be helpful for diagnosing and follow-up. So SpO2 by FiO2 of 235 is equal to roughly PO2 by FiO2 of 200, and SpO2 by FiO2 of 315 is roughly 300 of PO2 by FiO2. Other blood tests are increased CRP, increased procal in case of septic or ARDS, increased ferritin as an inflammatory marker we all know, increased IL-6 which is again another inflammatory marker and specific, not very specific, but it is lung-centric cytokine storm is marked by increased IL-6, and BNP is helpful because it can distinguish between cardiogenic pulmonary edema and ARDS. Where BNP is very high, it is suggestive of cardiogenic. When BNP is less than 200, it is suggestive of ARDS. Now coming to the microscopy or histological features. First of all, exudative phase. And we will divide it in three parts. Alveolar change, there is hyaline membrane on alveolar ducts or sacs, as we said. Interstitial and intraalveolar edema will be there, and collapsed alveoli can be there. As an epithelial change, there will be denudation and necrosis of type 1 pneumocytes. As we showed in the schematic diagram, type 1 pneumocytes are destroyed, but type 2 pneumocytes are not destroyed in the first phase. Now, in vascular changes, there is necrosis of endothelial wall, neutrophil aggregation, microthromboembolism, biplatelet aggregation, and hemorrhage. All these things can occur in exudative phase. Now, this is a picture of exudative phase. There is diffuse alveolar damage, and in this diagram, these hyaline membranes are highlighted by drawing the diagram. These are hyaline membranes, and type 2 pneumocytes are there. Type 2 pneumocytes we can compare with the left and right image. These are type 2 pneumocytes which are not damaged. Type 2 pneumocytes are intact and hyaline membrane is formed. This is exudative phase of ARDS. This is another image of diffuse alveolar damage, and there is formation of hyaline membrane. Hyaline membrane started to form in this picture. Next is another image of transfusion related acute lung injury. This is also ARDS, but there is a congestion part or hemorrhage part is more in this picture. Now coming to the next phase, or proliferative or organizing phase. The second phase, again in alveolar change, there will be organizing or remnants of hyaline membrane, interstitial and intra-alveolar proliferation of fibroblasts or myofibroblasts, and lymphocyte will come in the second phase, lymphocyte infiltration in the alveolus. In epithelial changes, there will be proliferation of type 2 pneumocytes, and in vascular area, there will be endothelial injury and thromboembolism in arteries and arterioles. So ARDS can give rise to pulmonary thromboembolism in this proliferative or organizing phase. This is some histological pictures of organizing phases. There is diffuse fibroblastic proliferation in this image. There is fibrosis everywhere, fibroblastic proliferation, and remnants of hyaline membrane is there in this picture. So hyaline membranes can be there in the organizing phase also. Now coming to the third or fibrosis phase. So alveolar change will be diffuse collagenous fibrosis, and microscopic honeycomb-like changes will be there in the alveoli, and traction bronchiolectasis may be there. In epithelial changes, there may be squamous cell hyperplasia, and in vascular part, there will be remodeling of arteries and fibrosis in intima with thickening of the media of the pulmonary arteries. So, how it will look like? This is collagenous fibrosis. In the fibrotic phase, there is collagen deposition in the alveoli and surrounding them, and there is vascular wall thickening. So what was it? Fibrosis of intima and thickening of media. Fibrosis of intima and thickening of media giving rise to vascular wall thickening. Next, so we conclude a brief discussion on ARDS. Now some entities which we left in the previous discussion. which is actually overlapping between interstitial lung disease and alveolar filling lesions. Three of them we left for today. First of all, there is cryptogenic organizing pneumonia, or COOP. Previously, it was called bronchiolitis obliterans organizing pneumonia. They can be drug-induced, of course, and amiodarone is one of the main culprits among the drug-induced cryptogenic organizing pneumonia. Radiation can also cause this, and they can be complication of pre-existing chronic diseases like RA, rheumatoid arthritis, like dermatomyositis, or inflammatory bowel disease. And what is the most important clinical finding in cryptogenic organizing pneumonia is chronic non-productive cough. Chronic non-productive cough. So, in the histology, which is characteristic of COP, patchy bronchiolocentric histological pattern. So, there can be fibroblastic plugs in alveolar sacs and ducts, which is called organizing pneumonia, and bronchial lumen when this is called bronchiolitis obliterans. Formed by spindle fibroblasts in pale staining matrix of immature loose collagen with polypoid shape, Mason body they are called, or there can be serpiginous or elongated form. So, organizing pneumonia sometimes extends from one alveolus to the next one through interalveolar fenestrae. Then it is called butterfly pattern. And mild to moderate cellular infiltrate may be there in background. We can contrast it with UIP. IPF, UIP, there is very less inflammation, and in cryptogenic, there can be mild to moderate cellular infiltrate. And thickened alveolar septa with lymphocytes, plasma cells, and histiocytes will be there. And alveolar architecture is usually preserved. So it is like similar to NSIP, alveolar architecture is preserved, and contrasting to UIP, usual interstitial pneumonia, where alveolar architecture is damaged. Next, because interstitial dense fibrosis and architectural destruction and honeycomb changes are not components of cryptogenic, when these things will be there is likely secondary to other lung diseases if these findings are there. So, foamy macrophage accumulation in surrounding airspace may be present, and occasional fibrin deposition may be present. But if fibrin deposition is prominent, then the lesion is more likely to be infection or eosinophilic pneumonia or vasculitis or acute fibrinous organizing pneumonia. So, this fibrin deposition is little bit of that can be tolerated in a diagnosis of cryptogenic. And there can be a psychiatrical form also, and organizing granulation tissue is collagenized or hyalinized and harbor eosinophilic, lamellar and dense fibers. And airspace can be filled with this collagenized organizing pneumonia, but as I already said, alveolar architecture is mostly preserved. So this is a histological picture of cryptogenic organizing pneumonia with gross hyalinizing changes of cryptogenic organizing pneumonia. Next come AIP, or acute interstitial pneumonia. These are also called Hamann-Ridge syndrome, and they are characterized by diffuse alveolar damage. And clinico-radiologically, my cause of discussing AIP in today's topic is also that it is very similar to ARDS clinico-radiologically. So I am discussing this together in the same discussion. Acute interstitial pneumonia can be infective, can be idiopathic. And again, there can be an exudative phase and an organizing phase. In exudative phase, there will be edema, hyaline membranes, and acute interstitial inflammation. And in the organizing phase, there will be organizing fibrosis, mostly within the alveolar septa, and type 2 pneumocytic hyperplasia. So, this is a picture of AIP. AIP, acute interstitial, acute pneumonia with DAD, or diffuse alveolar damage of proliferating or organizing phase is shown there because there is fibroblastic proliferation everywhere. So this can be done as a seen as an organizing phase of AIP. Next comes our third category, which we left in the previous days, discomative interstitial pneumonia. And this DIP is the most strongly associated pneumonia of non-infective pneumonia with smoking. And this again has a better prognosis. So I am not telling that smokers will have interstitial pneumonia or alveolar filling pneumonias of a better prognosis than non-smokers, because IPF is not associated with smoking, but DIP is. I'm not telling that, but there is a causal association, strong association of smoking with discomative interstitial pneumonia. And there is diffuse and massive accumulation of intra-alveolar macrophages or smokers' macrophages within the alveoli in DIP. And these are brown pigments, more finely granular than hemosiderin, and they are seen in the eosinophilic cytoplasm. Smokers' pigments they are called. And giant cells can also be seen. And there can be mild to moderate interstitial fibrosis or cellular changes. And diffuse and homogeneous involvement similar to NACIP will be there. And again we will contrast it with UIP, where there is patchy involvement, not diffuse. So larger biopsy, a more representative biopsy from different sites is needed for UIP. But diffuse and homogeneous involvement can be there in DIP and NSIP. And lymphoid follicles and eosinophils are often present, and marked dense fibrosis, architectural distortion, fibroblastic focus, or presence of intact alveolar walls in the area of accumulated macrophages should suggest another diagnosis. So, gross fibrosis, gross architectural distortion, or presence of intact alveolar walls in between the pathological areas, they suggest another patchy kind of infiltration, and there against the diagnosis of DIP. And as I said, smoking associated but prognostically better kind of pneumonia is this. And these are the images, histological microscopical images of DIP, where we can see in the alveolar spaces there is plenty of discomated macrophages or smokers macrophages, and there is little bit of interstitial fibrosis. But what we have said, that gross fibrosis will go against DIP diagnosis. Next comes another category of another content of the cup, that is pulmonary alveolar proteinosis. It is a rare lung disorder, and it is characterized by an abnormal accumulation of surfactant-derived lipoprotein compounds within the alveoli of the lung. The accumulated substances interfere with the normal gas exchange and expansion of the lungs, ultimately leading to difficult breathing and a predisposition to developing lung infections. So, the causes of PAP may be grouped into primary, that is autoimmune or hereditary, and secondary due to multiple diseases, and congenital also, usually genetic causes. And although the most common cause is a primary autoimmune condition, so pulmonary alveolar proteinosis is commonly autoimmune. This is a microscopic picture, alveolar spaces filled with proteinaceous material. Next come amyloidosis, as we said in the typification, but pulmonary amyloidosis is an exceedingly rare entity, and we all know that there is abnormal extracellular protein deposition in amyloidosis, which gives congruent positivity in special stain and in apple green by refringence in polarized microscopy. So, our next category is diffuse alveolar hemorrhage, or DAH, when the cup or the alveoli is filled with blood or hemorrhagic material. Now, it is a life-threatening and medical emergency that can be caused by numerous disorders and presents with hemoptysis, anemia, and diffuse alveolar infiltrates, all due to massive hemorrhage in the alveolar spaces. It comes out as hemoptysis, it gives rise to loss of blood, so anemia, and there is diffuse alveolar infiltrate as the alveoli are filled with blood. So early bronchoscopy with bronchoalveolar lavage is usually required to confirm the diagnosis and rule out infection. And most cases of DAH are caused by capillaritis, and they are associated with systemic autoimmune diseases such as anti-neutrophil cytoplasmic antibody associated vasculitis, anti-GBM disease, and SLE. But DAH may also result from coagulation disorders, drugs, inhaled toxins, or transplantation. So there is an exhaustive list of causes of pulmonary hemorrhage, starting from pathology capillaritis, where there is small vessel vasculitis, Wegener, Church-Strauss, microscopic polyangiitis, all this. And in secondary vasculitis, there is autoimmune diseases, SLE, RA, Upler syndrome, MCTD, polymyositis. And primary immune complex, there is good pastures, HSP, and essential cryoglobulinemia, Behçet's, lung transplant rejection, autologous bone marrow transplantation. All these will come in the categorization, and we will go for a short discussion or broad typification among the causes. Now, the first category is DAH associated with vascularitis or capillaritis. Most cases of DAH are caused by pulmonary capillaritis, as I have already said, and are closely associated with systemic vasculitis and findings such as ANCA-associated, anti-GBM, SLE, drug-induced vasculitis, etc. And the second category is bland pulmonary hemorrhage. Bland because this is without capillaritis or without vasculitis. And these epithelial lesions are usually microscopic and are scattered geographically within the lung. Anti-GBM and SLE can induce both pulmonary capillaritis and bland, both. And third category is DAH associated with another processor condition such as diffuse alveolar damage, inhalation, or cytotoxic drug therapy. So these are picture of pulmonary hemorrhage, and in higher power we can see extensive blood spillage within the alveolar spaces. Now we have during the classification of we have mentioned Church-Strauss as a cause of vasculitis. This is a disorder marked by blood vessel inflammation, and in a nutshell, this is most common symptom is asthma and necrotizing vasculitis, and extravascular eosinophil rich granulomatous inflammation can be there. So this is Church-Strauss, to recapitulate, and we come to our next category of alveolar microlithiasis. So this is an autosomal recessive condition caused by mutation in SLC34A2 sodium dependent gene, and normally expressed by type 2 alveolar macrophages. There is gradual onset and progression, and about half of the patients are found upon screening family members of patients, because most cases are asymptomatic, and even if the alveolar deposition is very extensive, symptoms are very slow or very gradual to happen. And average age of clinical presentation is around 30, but it can occur at any ages, including from inflammation. Starting from infants to any age, but the average age is around 30. And it may take decades to progress to respiratory failure. So it is a very indolent kind of alveolar filling disease. But there is no effective treatment except lung transplant. And in radiology, in chest X-ray, there is sandstorm of calcific densities, mainly lower and mid zone. And in HRCT, high resolution CT, there will be thickening and calcification of pleura, interlobular septa, bronchovascular bundles, focal ground glass opacities and consolidation, and subpleural cysts. So all this clinical radiological spectrum and strong family history association can give rise to the diagnosis without the biopsy. But the histopathology, as I said, the diagnosis can usually be made without a biopsy based on history and radiology, and ball fluid and sputum may demonstrate that calcified microliths, and biopsy will of course show diffuse filling of alveolar air spaces by calcospheroids. and lamellated calcifications, principally composed of calcium and phosphate, will be there. And in the late stage, there may show increased localization of subpleural, paraseptal, and peribronchovascular regions. And fibrosis and ossification will occur in some cases. So, this is a picture of alveolar microlithiasis. So, the broad categories of filling of the cup or the alveoli we have discussed, and the only category left is alveoli filled with malignant cells. But as I said, there is a series of lectures in this discussion in this month of pulmonary pathology, so neoplastic lesions will be elaborately discussed by many other speakers. I will not discuss at all, just a picture of bronchoalveolar carcinoma, and here filling the alveoli by malignant cells, and this is a in situ form of adenocarcinoma or bronchoalveolar carcinoma showing a purely lipidic pattern of growth. What I said, bronchoalveolar carcinoma is now renamed as lipidic pattern alveolar carcinoma. So, with this, I conclude my brief discussion on alveolar filling lesions. Thank you all for your patient hearing.
Thank you, Dr. Sukanta. Wonderful. A very difficult and a different lesion. Something which we don't see on a day-to-day basis, and setting up to teach such a lesion is itself a daunting task. It's not easy, because generally what we are seeing, that is something which excites us, and that is what we always want to talk about. But this is something which is going to be talked about in the near future, let me tell you. It is really coming up. If you follow the Western, people who are the way they are now practicing respiratory pathology, it's almost 70-30. 70% people are practicing this. The two lectures which you have taken, for them, 70% of their workload is this. It's just 30% of which is the one which the rest of the people will be talking on, the respiratory tumors, the neoplastic lesions. And as things are progressing, this is going to come to our setup also more frequently. All what you have talked on Wednesday and on today is primarily a mixture of lesions which SARS-CoV is presenting with.
Yes.
So let me tell you one thing. This is it. This is the disease. This is the histology or the pathology of the near future. And it is much important for all of us to get used to it. Let me tell you one thing that I can be sure of, that 95% of us know nothing about this. And on a biopsy, on a true cut biopsy, if we don't see a tumor, we are caught up. If it is a tumor, you don't have to say anything. Everybody knows what to talk. Somebody will just leave it at non-small cell and small cell, and somebody can go up to molecular and talk it out to the finest. But if there are no tumors, and it is just alveolar spaces filled with some pinkish material, with some cells, lying here and there, some proliferation of the, of the lining epithelium, bas, we are all stuck. Then we have.
What is this? ILD is okay, but what is the alveolar filling lesions?
Yes, exactly. In fact, when I was trying to list up the topics, I wanted these topics to be addressed very sincerely, very aggressively, because as we talk to people across the globe and try to talk to them what type of work they are doing, we realize that this is it. And yesterday I was just discussing with Dr. Sanjay Jogai, who will be taking a class tomorrow. He was very impressed with your lecture which you took on ILD, and he was telling me that Dr. Sukanta Chakraborty has laid down the background. Yes. Now my job is just to put the fills here and there, because he's practicing respiratory pathology there and at Southampton, and he's telling us that this is what we are seeing every day. Aren't you people seeing this? I said our respiratory physicians are yet to realize that they can even hit a pneumonotic lung patch and come out and tell us exactly, now look at this and tell us something more. And this is going to happen. What is happening in the West today is going to happen to us tomorrow. So you will be much in a better position to handle these true cut biopsies than any one of us. I can bet on this. Every day, whenever we see a true cut lung biopsy, and if we don't see a tumor, we are over. Bas.
Yes, sir.
We have no answer. We will give a descriptive report, no evidence of any malignancy, and we will stop there. But very soon we will be getting more lung biopsies where they will give us a history, like they give a history to a nephrologist.
Yes, sir.
And now tell us what is it, whether it is DIP, whether it is a non-DIP lesion, what it is. Try to pinpoint out and then tell us exactly whether you are seeing any vasculitis there, what type of lesion is it IgG4 type of lesion or not. And then that time, this is a very tough topic which you have addressed so lucidly, so nicely. I'm so thankful to you that you have addressed. I had seen earlier that you had taken a talk on the respiratory physicians on ILD. So I knew that you are the right person to talk on these two topics. And I'm so happy that you have really done so good to these two topics. You have done extraordinarily well. Let me congratulate you for that.
Thank you, sir.
Right. Thank you so much, Dr. Chakraborty. We will surely see you soon in the next month or the month after that with dermatopathology. And if any other topic, if you have any topic to talk about, then we can always put that across. Please let me know. Right? Okay, then take care. Bye-bye. Good night. God bless you. Thank you. Bye.
Good night. Good night.
Good night. Bye.